Okay. Good morning, everyone, and welcome to another Grand Rounds. I'm very happy today to introduce two speakers. Our first speaker will be Dr. Randi Foraker. She got her bachelor's and master's of arts at the University of Iowa before getting her PhD in epidemiology at the University of North Carolina, Chapel Hill. And then after a stint at Ohio State University, she's been here with us since 2017 as an associate professor and a director of the Public Health Data and Training Center, as well as the director for the Center for Population Health Informatics. She's worked on a broad range of projects, and today she's going to talk to us about data-driven approaches in the COVID pandemic. Our second speaker is going to be Dr. Jeffrey Henderson. He received his bachelor's in science at the University of Wisconsin-Madison before coming here for an MD and PhD, and then continuing on at Washington University for his internal medicine training and ID fellowship. He's currently an associate professor and co-director of the Biochemistry, Biophysics, and Structural Biology graduate program. His research is focused on understanding pathogen virulence, and he is going to talk to us today on convalescent plasma transfusion for COVID-19. And Dr. Foraker, if you're ready, you can take it away.
Thank you, Dr. McDonald. It's my pleasure to be here today to talk to you about the great work that our teams have done collaboratively to date around COVID. And I want to begin today with introductions and acknowledgements of all of the people who have been involved with these projects to date. This has truly been a team effort, and that's why I want to call out each of these groups individually before I get started. And I'm going to be referencing to them and their work as I go through the slides today. From where I sit in the Institute for Informatics, faculty and trainees in our labs have joined forces to carry out a lot of these data analytics efforts. We've been supported by informatics core services, including the data brokerage teams for accessing electronic health record data, as well as the application development team. The project management office has also been instrumental in bringing all of these groups together. We've worked daily side by side with BJC Healthcare, particularly the Center for Clinical Excellence, as led by Keith Welchie. And we've also worked and brought together a task force with the departments of health in our region, particularly St. Louis City, St. Louis County, and St. Charles County. We've also leveraged the important work of the Institute for Public Health as a connector of all of these entities. The faculty scholars in the Institute for Public Health have certainly stepped up as well to help with not only epidemic modeling, but also engaging with the departments of health. The faculty scholars that I would like to mention, although there are many, are Elvin Gang, Karen Joint-Maddox, as well as Hillary Reno. The Public Health Data and Training Center plays an important role. Right now, what they're doing is helping us better understand what data assets there are in the region and what variables we have access to in order to carry out this work, including epidemic modeling, but also predictive analytics and geospatial analyses. And the Public Health Data and Training Center, particularly Ann Trollard, is partnering with the Regional Data Alliance, led by Ben Cooper, in order to do this data assessment. And the Institute for Public Health, particularly the Data and Training Center, serves as an honest broker of data between the health systems and the departments of public health. And so we're an important conduit of these data and can enable these region-wide analyses. And in speaking about the Institute for Public Health as an honest broker of these data, the data assets that I spoke about earlier coming in from the departments of health or in from the health systems come into the Institute for Public Health as an honest broker. The Institute for Informatics helps us build this COVID data commons that can be leveraged for data analytics. So when these data come in, we work with those stakeholders that I just mentioned, to collectively identify the data analytics needs in our region. We also work together, but also independently in an efficient way to deploy rigorous methodology and generate evidence from these data. It's then an important piece of this puzzle to communicate back the results to our stakeholders. And we do so, if not daily, then multiple times per week, and at a minimum weekly. So we're keeping everyone informed of our efforts and making sure that there aren't any redundancies in this system. And our ultimate goal, of course, is to improve lives in our region. So first, I'll talk about the regional impact of our work, and this has been accomplished by aligning with our healthcare systems in the region. And I've mentioned how we've worked alongside BJC, but we have also convened forces with SSM and Mercy and St. Luke's. And one of the biggest undertakings that BJC and the Center for Clinical Excellence has achieved is bringing together these groups to better predict the surge. Particularly here, what's shown is the surge in inpatients as it relates to COVID. And what they've done alongside Elvin Gang and others is built a prediction model to estimate the reasonable worst case, which is the red line here, the reasonable best case, which is the blue line here, and then also to track along this black line what's actually happening in our region with regard to inpatient census counts. And this group is continuing its important work to predict the surge, but also they're transitioning to also predict post-surge trajectories. And we're in the very early stages of bringing in the Division of Biostatistics to help us in this regard, particularly as it relates to simulations and what might happen post-surge as we prepare to perhaps relax social distancing restrictions and return to work. We have also conducted geospatial analyses to identify at-risk communities. A PhD student, Josh Landman, in our lab has created a Tableau visualization showing BJC diagnoses for COVID on this map. And when we receive Mercy and SSM and St. Luke's data, those will also be incorporated into this map. We've developed a system to share this Tableau workbook with our stakeholders so that they can also use these data in their analyses. And what's particularly concerning about this map is that the prevalence of COVID is high in our traditionally underserved area of the region. And we hypothesize that this is due to perhaps a lack of social distancing due to the essential occupations that these residents may hold relative to the rest of the region. And also it concerns us because traditionally residents of these communities have a higher burden of comorbidities. So when they do get the virus, they tend to have worse outcomes relative to healthier individuals. Speaking of demographics, we have done logistic regression analyses on BJC data, and we will repeat these once we get the region-wide health system data in hand. But what you see here are odds ratios and confidence intervals for the predictors of age, gender, and race. And you'll see that for every year increase in age, the odds of ICU transfer increase by 3%, the odds of mortality increase by 9%. Males have approximately twice the odds of ICU transfer as compared to females, and over twice the odds of mortality. African Americans, meanwhile, have about 25% higher odds of ICU transfers compared to whites, and about twice the mortality rate. And again, we are going to extend this to include the rest of the region, but also we're looking to include comorbidities in these models. Note that these are now currently based on about 1,000 unique COVID positive patients. We have also done preliminary work. This has been completed by Sean Yu in our labs at I2. And what this diagram shows are patient trajectories. And these are COVID positive patients who have passed through the ICU at least once. And the green arrows indicate that these individuals have lower than the average mortality rate. The gray arrows show that these individuals have the average mortality rate. And the red arrows show that these individuals have above average mortality rate. And these are their trajectories through the system. The weights or the thicknesses of these arrows represent the number of patients that are in this particular path in the model. And what we hope that these diagrams can help us do is intervene at critical points in order to prevent adverse outcomes among these patients. I also mentioned that we've aligned with departments of health in this effort, and this has been critical to better understand what data assets they need and what analytics they may need assistance with. We've conducted some street-level geospatial analyses to help us identify hotspots in our region. And I want to be able to show you this movie. Here we go. I need to undo my laser pointer for a moment to do this. There we go. So these are street level data. And what these street level data show are influenza-like illness and COVID positive diagnoses since January 1. And what these street level data are going to help us do is zero in on where we need to apply our public health efforts. So when we think about the underserved communities that I was telling you about earlier, this would allow us to zoom in to identify hotspots, not just at the zip code level, but at the block level or at the neighborhood level. And this would not only assist in getting educational messages around social distancing to the people who need it most, but also to allow us to do contact tracing. And when we do contact tracing, we can integrate those addresses into this map as well. And only a select few people would have access to a map like this because you can zoom into the street level. And so we're going to be sure that this visualization is stored on a secure website and is accessible by our colleagues in the region in public health. At the Institute for Public Health in Informatics Core Services, our REDCap team has developed a contact tracing form and database in REDCap at the request of St. Louis County Department of Health. And this will enable them to do better, more efficient contact tracing and inform who should quarantine. And this will help us as we continue to control this pandemic in our region. Last but not least, I would like to talk with you about a national network that we are a part of at WashU, which leverages a synthetic data platform. And this synthetic data collaborative has been made possible by the National Center for Advancing Clinical and Translational Science, or NCATS at the NIH, alongside the private entities of MD Clone and Microsoft. But first, I wanted to tell you a little bit about MD Clone and its instance here at Washington University, because this can be a critical asset for researchers moving forward. Very briefly, I would like to show you how the clinical data are entered into our research data core at the Institute for Informatics. These data are in turn loaded into the healthcare data lake for MD Clone. And an MD Clone user then can log into the query portal and build a cohort and select variables based on the data that are available in the healthcare data lake in order to generate synthetic data derivatives. And what these synthetic data derivatives are they're based on the real data that exist in the healthcare data lake, and they maintain the statistical properties of those data. However, the rows of the real data don't correspond one-to-one with the rows of the synthetic data. So this process generates a set of synthetic patients with data that look and feel like real data, but don't correspond one-on-one with the data, with the real data. And my team at the Institute for Informatics has a paper under review demonstrating that the use cases that we've conducted in MD-Clone, 3 of them, produce the same results on the synthetic data derivative as they do on the real data. So as you can see, leveraging this particular asset, not only within WashU, but also in this synthetic data collaborative, can be very powerful, particularly in the setting of the current COVID pandemic. And so what we are aiming to do with this national collaborative is have several data providers, several different institutions, providing a limited data set of COVID data. So not only clinical data, but also that of supply chain and personnel, and feeding these data in to a larger MD-Clone data lake that comprises these data from multiple institutions. And then these data can be leveraged by that synthetic engine to produce synthetic data sets for greater insights. And this is important because it will allow us to pool our data assets, but also get answers to these critical questions much faster than through traditional pathways. So I've spoken a lot already about the important work that we've done as a university and hospital community to respond to the COVID pandemic. But what I'd like to highlight now is how we can get involved as researchers, because I know a lot of you have COVID-related research ideas, and I wanted to give you a sense of how to bring those to the forefront and perhaps even find collaborators working in the similar realm across the university. Your first stop should be the Institute of Clinical and Translational Sciences website. If you click on this blue button and submit a brief form describing your project, there is a review committee that will review the project for feasibility. And also they will ascertain what resources are needed and if we have those resources. So a good example might be if an investigator wants to use data that we simply don't have, this committee can recommend to the investigator that if they want to follow through on this protocol, then they need to be able to ascertain those data elsewhere. So this committee will also look for overlap with other study protocols to ensure that no one is doing inefficient work, doing the same work. So they may put 2 investigators together to work on the same IRB protocol after approval through this committee. The next step after approval by this committee is to submit your protocol to the IRB for approval as usual. And I'm just going to close with getting started in terms of having the appropriate resources to conduct your COVID research and other types of research as well. So the first link is to the Institute of Clinical and Translational Sciences website that I just pointed out. And then I'm also including an email address if you wish to get started on the WashU instance of MD-Clone to enable your research. And with that, I thank you for your attention, and we are going to transition over to Dr. Henderson.
All right. Good morning. Terrell, it's not letting me share my screen.
Okay, give me 1 second. Are you able to do it now?
I believe so. Good. All right. Good morning. So what I'm going to talk about today is the use of convalescent plasma transfusion for COVID-19. Sorry, slide advance here. There we go. No disclosures. Right, so what I'm going to describe is, I guess, is a study that's a little bit outside the norm for what I normally do. And just by way of introduction, I wanted to kind of provide this timeline here of COVID-19. Just recall that the first case was identified in November, and this is something of a look back to identify what was believed to be the earliest case. The first US case, of course, appeared January 20th of 2020. And in this gap in February, I was not working on COVID. I'm not a coronavirologist. I had been part of a kind of digital community, if you will, of other academic researchers discussing this topic. And Arturo Casadevall at Johns Hopkins, who's something of a historian, in addition to being an infectious diseases researcher, had raised this possibility with the group of using convalescent plasma, or kind of classically known as convalescent serotherapy. There was some discussion of this, and as we looked ahead, it seemed to fit this gap. As we knew COVID was coming to the US, was likely to increase in the number of cases. What were we going to do? What were we going to be able to offer patients? Of course, there's intense interest in developing a vaccine, in developing things like monoclonal antibodies, or identifying antiviral agents. But the thought was, these are things that are much further out in the timeline, and we had to consider some possibilities that could be mobilized more quickly. So this is an outline of the general idea. And for those not familiar with the use of convalescent sera for treating infectious diseases, this is a procedure where you identify a patient who has recovered from disease and is well into the convalescent period where symptoms are gone. They've presumably developed and matured an immune response. Classically, blood is drawn from these patients, allowed to clot. The serum is collected. The serum contains antibodies to the infectious agent. And then that serum is essentially used as a therapeutic. In many cases, in the past, it's been used for prophylaxis at an early stage of illness, or to passively immunize those at high risk for developing an illness. But it's also been used as therapy in those who've already developed it. So this is a kind of classic mode of antibody therapy. And to go back and look at the use of convalescent plasma is really to kind of go back over the history, I think, of infectious diseases and microbiology. It has a very long storied history. Its early uses focused on bacterial infectious diseases, diphtheria, pertussis, pneumococcal disease. Those early uses, of course, involved agents in which a toxin was a predominant part of the pathophysiology. But later on, and it was also deployed for viral illnesses, notably influenza, the 1918 flu pandemic. It's been used for measles, mumps, polio, more recently for SARS and Ebola. So you'll note that a number of these uses are for diseases for which there are now modern vaccines. And because of this, to some degree, I think the use of convalescent plasma maybe isn't on the forefront of people's minds. An advantage of using this in the present situation is its deployability at scale. We no longer are using plasma or serum rather per se, but we can use plasma. There's a high capacity for this in the US blood banking system. It's safe. There's extensive testing and experience with transfusions. So this is something that could be theoretically deployed quite quickly. As I mentioned, it uses this very well-established plasma donation process. It is not regarded quite so much as a new drug as perhaps something like an antibody preparation or a monoclonal antibody or a new antiviral agent, for example, and therefore there's really a lower FDA hurdle for the use of plasma than there is for a drug antibody or vaccine. So, to go back and, in thinking about how we would use this, you can go way back. Serum therapy was first developed around 1890 was when experiments began. And this was actually the subject of the very first Nobel Prize in Physiology or Medicine in 1901. That was awarded to von Behring. But notably, Kitasato Shibasaburo was also very much involved in testing out antisera. And this is all for work on diphtheria initially. Von Behring's work kind of developed to the point where they had a herd of horses, so they were ended up using horse antiserum for diphtheria, and with the success of this, the general approach moved on to tetanus and a number of other illnesses. In the pre-antibiotic era, so serum therapy was also quite useful, and there's some really nice descriptions of its use in 1930s. Max Finland it describes that serum therapy for pneumococcal pneumonia made people feel better and worked quite early. And I think this is an interesting point. I mean, I haven't, in my career, certainly haven't treated people for things like pneumococcal pneumonia with sera. But a lot of the descriptions, if you read them at the time, were not that this was a marginally effective therapy at the beginning. Many physicians noted a very rapid clinical improvement in these patients. Notably when antibiotics came along, when penicillin came along, in the very early uses, people were quite nervous about it because many felt that serum worked faster than antibiotics. Fortunately, when you go on and watch the patient for a longer duration, penicillin appeared to be to work better in the long term. But I think it's notable that some of these early uses of serum are consistent with a pretty good efficacy, at least for some diseases. One of the challenges of looking back over serum or plasma therapy for illnesses, and particularly viral illnesses, is it's classically a therapy given under duress. It's given in a large influx of cases and mortality, and physicians are kind of under stress to find anything. It's hard to conduct a properly controlled study and set one up in these circumstances. So going over the literature can be something of an adventure. There have been some attempts to do good meta-analyses of efficacy. This one from the Annals of Internal Medicine looked at the use of plasma or serum therapy in the 1918 Spanish flu, and carefully selected six studies they deemed of reasonable quality, and looked at the progression to mortality in these, and overall found an improvement in survival. Now, one can debate whether this was also treating the superimposed pneumococcal pneumonia in this group. Remains a topic of debate, but nevertheless, there appear to be some efficacy of this. If you look at some very careful descriptions of the use of convalescent serum, there's some really nice ones, one in a naval hospital. These were physicians treating patients with serum, bleeding them in one room, having a set of sera, looking at the effect of that sera, finding donors whose sera was particularly potent, and then using those. And on individual kind of case-by-case studies, you can perceive a fairly substantial benefit at certain locations. Perhaps more relevant to COVID-19 was the experience with SARS coronavirus 1, or the SARS outbreak a number of years back. These tended to be somewhat small studies, but a meta-analysis in the Journal of Infectious Diseases in 2015 put these studies together and came up with a mortality odds ratio of 0.25 for the use of convalescent plasma here. Appeared to have some benefit in looking through details of its use, which certainly varied by location. The benefit appeared to be more marked when the plasma was given early after symptom onset. But this is kind of the data you get in the midst of epidemics. So, certainly promising here in that this is a virus that is fairly related to SARS-CoV-2, the COVID-19 agent. So, looking over at data, and data, of course, new data comes out almost daily, much of it from China, from Wuhan, and from Hubei province. What's shown here is a time course of the antibody response in 137 patients in Wuhan and Hubei province, looking at days after the onset of illness, and here's percent of seroconversion. And so if you look at the total antibody in red, IgM, IgG, these things march out in their canonical order, IgM preceding IgG. You get a median seroconversion in the 11 to 14 day range. So there is a period after the onset of illness where antibody responses are fairly low. And some other data that's starting to come out would indicate that the ability of antibodies to neutralize virus marches out in somewhat similar order to this, that a truly mature neutralizing response appears somewhere after 2 weeks after the initial symptoms appear. So if indeed antibodies are important for defense, for immune defense against COVID-19, which they appear to be, then these patients are moving through a period in the first couple weeks where that antibody defense is somewhat deficient. So, of course, and you can note the dates on these, new data comes out fairly regularly. Convalescent plasma, turns out, was used in China. There were murmurs of this early on, about a month ago, and we're seeing more and more data come out in this regard. These are not, as is par for the course in an epidemic, these are not highly controlled trials. These are kind of clinical experiences with perhaps historical controls, one of which was reported in JAMA on March 27th, describes 5 patients that were transfused with a high titer plasma. In this case, this was greater than 1 to 640 plasma titers against the virus. Their note was that the plasma therapy was well tolerated. It resulted, or was followed, I should say, by improved oxygen saturation, multiple lab measures, things like lymphocytes, and patients were extubated. You often get these kind of uncontrolled reports, so this sounds good. It's not a controlled trial, but encouraging. And there was a larger, and by larger, 10 patients reported in April 6th Again, transfused with high titer plasma, this time over 1 to 1,000 plasma titers. All 10 of these patients also appeared to tolerate plasma quite well, and were also followed by improved oxygen saturations. Most of the lab measures that were associated with COVID-19 and numerous extubations and release from the ICU. So this is kind of, this is what we're working with as far as data on COVID-19 at the moment. That could all change as of next week. So, just to review back, how can we implement this in this country? How can we implement this locally? So, again, as I mentioned, this was kind of began as a discussion among a number of academic medical centers. A position paper, if you will, was kind of put together. Arturo had this published in the Wall Street Journal on February 29th, followed up by a more scholarly proposal in March 13th in the Journal of Clinical Investigation. This group, and it's kind of taken form over this time, kind of obtained a National Academies of Science endorsement of the concept. A FDA IND was submitted. The FDA approved convalescent plasma for COVID-19 on March 24th. But this was done not for a trial, but for compassionate use as an emergency IND. One of the first uses, at least in the States, was at Houston Methodist, a place with its own blood banking. They transfused convalescent plasma for COVID-19 in a number of patients there. The FDA on April 3rd announced an expanded use IND, which kind of facilitates or makes this process easier for participating institutions. And this was followed up with the first use last weekend on April 11th at WashU, Barnes-Jewish. So what have we put together locally? We have a local convalescent donor intake process now that Rachel Presti has put together. We encourage those who have had a positive past COVID test to contact her and contact this unit at idcru@wustl.edu. Since last week, a number of people have come through the process, and the qualifications to do this, right, of course, have to be able to donate plasma, have to have a positive previous COVID test. That certainly limits the number of people available. We need people to be 14 plus days away from their last COVID attributable symptoms. And once they come through, we need to administer a repeat COVID test if they're between 14 and 28 days away from their last symptoms. This is a requirement of the blood banks who want to make sure that their blood collection facility sites are safe. Patients should also have a demonstrated serologic titer to COVID-19. Also a challenge, right, because serologic tests are new at an early state. So these are the qualifications in the process we go through for this. Once qualified, local patients are sent on to the American Red Cross. There are a number of national blood banks that will participate in this. Hospitals that have their own apheresis units have participated in this as well. This is just standard apheresis and plasma donation. Once that is available, Barnes-Jewish, we work through an expanded use IND, and patients who are candidates for this have established COVID-19, hypoxemic respiratory failure, and ideally are less than 14 days away from the onset of symptoms without improvement. The selection of these patients and transfusion is led by a team of Derek Byers, Rachel Presti, and Brenda Grossman, our Director of Transfusion Medicine. So progress to date. So donation, we've seen over 30 patients or 30 donors, prospective donors come through. 27 have been referred on for apheresis. They've been referred to the Red Cross, and Red Cross doesn't necessarily give us feedback on how many have showed up and donated, but suffice it to say, Red Cross pools from regions that plasma is prepared there. It's designated as COVID-19 convalescent plasma. And to date, 5 patients have been identified and transfused at Barnes-Jewish. 4 of these have been ventilated. 1 was on a non-rebreather with respiratory failure. So what's next? Well, what we're doing right now is not a study per se. It's compassionate use style administration. But we're looking forward to seeing what anecdotal responses and clinical experience has been with plasma. As part of this national network, we hear, bits and pieces from places. The largest cohorts of patients, not surprisingly, have been in New York. Mount Sinai probably has the largest group currently of plasma-treated patients. The murmurs from there are positive, but we await a kind of more sophisticated reporting of exactly what the experience there has been. Other items are, more sophisticated selection of donor plasma. As I mentioned, classically in 100 years ago, it was delightfully simple. A treating physician could obtain sera from numerous patients that have recovered, use that serum, watch the recovery of the patient, which sometimes was fast enough to give feedback. They would repeatedly go back to donors whose plasma gave positive responses. And so there was kind of a tight loop between evaluation and use. In our current day, there's a lot of regulation, and there's kind of a bucket brigade between plasma to use, so a lot of our effort is going to tightening that loop, to getting some kind of characterization of the donor plasma that we believe to be connected to patient outcome. It would be nice to identify high potency donors, et cetera. We don't know for sure that a high titer antibody response corresponds to efficacy. You could go the other way around, that viral neutralization. There's always debate about how important that is as well, but to the best of our knowledge, both of these should be important indicators of a potent donor plasma. Also of interest is use in milder illness in preventing progression of patients who are seriously ill to a ventilator. This is more in line with the past use of convalescent plasma, but we'll await with interest to see what the experience is in sicker patients. A number of trials are in design right now. One of these is for prophylaxis of exposed family members of those at high risk for acquiring COVID-19. Again, this trial's in early stage. COVID-19 patients are in design, as well as a more formal trial in ICU type ventilated patients with the disease. So in the way of acknowledgements, acknowledge kind of 2 groups here. So one is the COVID-19 Convalescent Plasma Project. If you want to check in on this, it's at ccpp19.org. That site also contains a registry for those that are outside the St. Louis area interested in looking in donating plasma. Inside the St. Louis area, people should just go to idcru@wustl.edu. This plasma project team is kind of loosely coordinated by a board of Arturo Casa-Deval at Hopkins, Mike Joyner at Mayo, Lizanne Perofsky at Einstein, Shmuel Shoam at Hopkins, and Nigel Paneth at Michigan State. Our local team is really headed by Rachel Presti in medicine, infectious diseases, a wonderful infectious diseases trialist. who's helped move this process through. Brenda Grossman, who's also on the national group, has been a fantastic resource. Nobody knows blood banking better than her, as far as I'm concerned. And she's really facilitated things, I would say, at both the national and the local level. Ale Elibetti in PATH has worked with us on implementing serologic tests of donors. Mike Diamond and David Fremont have worked with the group as well at ways to better identify good plasma donors for this. I point you to funders as well, and that's a little bit gratuitous. Barnes Jewish Foundation has been wonderful in making funding quickly available for this effort, as has been the WashU ICTS, some industry support in Octapharma. And I've always wanted to say that the National Basketball Association, the NBA, has contributed to this effort as well. You can note that there are some absences in the funders, and I will leave it at that.
Thank you both so much for your excellent talks. We do have a couple of questions. And I think I'll start with questions for Dr. Henderson, because you are right here. And so one of the questions is, the timing of antibody infusion seems like it would be critical, since the later effects of COVID-19 seem to be immunological and not viral pneumonia. Can you discuss?
Yeah, this is an area of intensive discussion. And, early on when we were deciding what would be the best use or what would be the ideal patient population, the thought was, conservatively to give to people very early in the illness prophylaxis of people who were exposed, or those, it was considered somewhat adventurous to go into those with early illness. So, this was the bias of the group as well. The early emergency IND went to the opposite population, to those with fairly advanced disease. It's quite possible that there's still some benefit in those, but there was a lot of concern that that the horse was out of the barn, so to speak, and that there were a lot of non-viral pathophysiologic processes that wouldn't be intervened. Time will tell whether that's truly the case. The other thing I would mention is, that one of the unknowns about serum therapy, and Lizanne Porofsky is really versed in this, but one of the unknowns is the kind of immunologic or anti-inflammatory properties of some antibodies as well. It's possible that serum therapy could improve disease at a later stage through those mechanisms.
Excellent. And then I'll give one more question for Dr. Henderson. There are several questions that are kind of looking at some issues with the mechanics of using plasma. So, how do you determine the dose or the frequency, or how many, when there's one plasma donation, how many people can that treat? Or if you can identify, monoclonal target antibodies from a pool from donated serum. Do you have any thoughts on that?
Yeah, this is a great question, and it's a real challenge, right? So if we're using immune plasma, I mean that's it's not quite like a drug that way, right? We don't truly know its potency. We don't necessarily even know what to measure to assess its potency, and we have some ideas of that. What we kind of revert to is standard practice in blood banking, which we give plasma in terms of units. And so to date, that is the dosage unit that we give. Historically, people were bled, and something like 20 cc's of that plasma were given. A unit of convalescent plasma may well be far in excess of what's necessary. But I think time will tell on this one. But what we've reverted to is the use of kind of standard unit denominations. We've done some pharmacology modeling and so forth about what an ideal use might be, but have not kind of implemented it on that basis just yet. I think there is a remarkable opportunity in this, in that a look-back analysis, we could look back with enough patience at somebody's serum, perhaps retrospectively identify features of the serum that were associated with a good outcome. That would be a great vein, perhaps, to mine for particularly potent neutralizing antibodies. But this is really on the chalkboard at the moment.
Excellent. Thank you so much. And for Dr. Foraker, I see that she's been busy answering questions in the Q&A section, so you can look there to see her answers to those questions. I will give her a question from the chat, though. Have you been able to compare trajectories of the people in your interest who tested negative for COVID? I believe this is when you were looking at where people went from, ED or floor or ICU initially, and where they went from within the hospital from there. And then the question is, this may be a useful control for when we have false negatives who have adverse outcomes.
Yes, thank you. And great talk, Dr. Henderson, as well. So I think this is a great idea to use persons under investigation who did not develop COVID as a potential control population for not only the analyses that you mentioned, Dr. McConnell, but also the analyses that I showed you of the demographics that are associated with outcomes among these patients. And I did see another question that was related in the chat box from Kristen, who asked whether those odds ratios that I just referenced were adjusted odds ratios, showing, for example, the 9% increase per year of age in the transfer to ICU outcome. Those were adjusted odds ratios. So just to clarify that for her as well.
Perfect. And I think we'll have one more question for you. And that was, how can you use your data to better estimate prevalence in different communities given the limited testing we have done and the geographic distribution of testing centers, which has not been aligned with the hotspots? And I also thought that when you showed that initial map, I believe that was just the Barnes data, so it'll be very interesting when we see the other hospital data that serve different areas of our greater community as well.
That's right. And I think to this point, a lot can be done with what we call descriptive epidemiology to better understand the prevalence in certain areas, not only in zip codes, but using the street level data that we have, being able to aggregate these patients to smaller units, for example, the census tracts that they come from, to estimate prevalence in that regard. I think it's also important to conduct analyses, much like the logistic regression we've already conducted, to account for the clustering of patients geographically, because there could be something about that location that predicts above and beyond their individual characteristics like age, race, gender, and comorbidities. And so that is a next step for our group as well, to delve deeper into the geospatial analyses.
Thank you both so much for giving grand rounds. Take care.
Thank you.
Thank you.